Thanks for joining today. My name is Claudia Soiland-Reyes, and yes, as Jess mentioned, I'm going to be sharing a bit of the experiences on my pre-doctoral fellowship, and the talk today is Population Health Research and Integrated Care Systems. So the content of my talk today, I will share a bit of experiences and hopefully motivate others to explore this type of fellowships and also to highlight the role of population health research in improving health, especially given now the new opportunities provided by the formation of integrated care systems. So a bit of background about myself. So I'm a senior project manager based at the Research and Innovation Department at Salford Royal. And I manage the Diploma Evaluation Program, which is led by researchers at the University of Manchester and UCL. So you may have heard of the NHS Diabetes Prevention Program. And diabetes is the NIHR funded evaluation of this program, and it aims to assess if the NHS TPP reduces diabetes in a way that is cost-effective, sustainable, and equitable. So here you see an image of a video that the PPI group produced, and this is to explain what's the aim of the evaluation. And there's a second video on the findings of the evaluation. So if you have a chance at some point to have a look, please do and share. So this is my role in Diploma. Previous to that role in Diploma, I work as a facilitator and as a research associate for projects in the Clark Greater Manchester in a range of projects. But before that, I also worked in the private sector for some years as a business change and a project manager. And my academic background is in operations research, which uses problem-solving methods and techniques to find ways to make the best use of resources. So, given my background and during my work in Diploma, I realized I wanted to work as a researcher again. So to do that, because I was a bit the work I have been doing was not as a researcher itself. So talking to a colleague, she mentioned about the NIHR Academy opportunities. And that year in particular, when I had a look, there was a new type of fellowship created, the pre-doctoral fellowship, not to do a PhD at the moment, but to support people who wanted to do research training, potentially leading to a career, a future PhD and an academic career. And there are 9 types of training areas supported. And in particular, for me, I was interested in applying operation research and modeling methods, learning about those. More commonly, people use this type of fellowship to do a master's degree if they don't have one. The fellowships will cover your salary while you are training. So if anyone is interested, have a look at the NIHR Academy site, and I'll be happy to help answering any questions and share my experiences with you. There are research possibilities for nurses, clinicians, doctors, and non-clinical staff, people as myself. So because in my case, I already had a master's degree, I used my fellowship to learn more about public health by doing some standalone courses at the university at the master level, and especially wanted to learn about training and modeling methods to estimate future benefits of interventions implemented by government to improve and prevent illnesses and improve health. So I did my training on a part-time basis while I was still working in Diploma. My host was Salford Royal, and I did this, most of my training was in collaboration with the University of Liverpool, but some of it also was with the University of Manchester. So population health is about helping people being healthy. But more and more now, we know that being healthy is more than just not being ill. It's about our physical, mental, and emotional well-being. So having access to a first-class healthcare service as the NHS to treat us when we are ill is not enough, and as we know, it's not sustainable. So we know there are other factors that affect our health, such as our jobs or the lack of it, support groups, our networks, the place we live in, and the services that are available. So the aim of the population health is to ensure everyone has the same opportunities to have a healthy life. But we know there are wide inequalities in health. So for instance, the difference in healthy life expectancy between males born in the least deprived areas of England compared to the most deprived areas can be up to 18 years, over 18 years, in the case of the males, for instance. There's a video here, a resource from the King's Fund, which explains very well about the complexities of providing population health, the challenges and the wider factors and participants in making this happen. So have a look if you can again. So population health research, it produces the evidence needed to inform delivery of mainly non-NHS interventions to improve health. There are different types of interventions depending on the point at which help is being provided. So a commonly used analogy is this of a river. So you have the people downstream in the river, something's happening, they're being seen drowning. So you imagine walking with a friend, passing by a person drowning, help them out into safety, and there's a new person coming, and again, you more manage to kind of help people out and then safe of the danger. So the friend walks upstream the river to see what's the reason why this is happening. In the way you can see people in need of help, and he throws a lifesaver ring so they can help themselves out of the river and into safety, and keeps walking further upstream and finds that there's a broken bridge. And that's the reason why people is unaware of it and they're falling out into the river. So he can place a sign to warn people, or they can fix the bridge, or they can do both. So this can take extra resources time, and it might not be as easy as just taking people out of the river, but it's a longer term solution. So this is while the NHS on one side is helping people when they are in imminent need, public health is looking at this kind of area of interventions that can help prevent ill health in the first place. So I did my training in population health with the non-communicable disease, which is a policy research group at Liverpool. They research state-of-the-art methodologies to analyze, interpret, and promote effective and cost-effective policy interventions to promote health and prevent non-communicable diseases, which non-communicable diseases are diseases like diabetes, stroke, cardiovascular disease, which in the UK are responsible for 9 in 10 deaths. So also their work is mainly in 2 areas, modeling cardiovascular epidemiology and also prevention policy, particular in food area. Now this is one of the models. This is just an illustration of one of the models they developed. I'm not going to go too much into detail. It's a very complex model that took a long time for the group to develop, but roughly, very briefly, this model has been used widely in US, UK, Brazil, and now in other European countries to evaluate the impact of interventions in preventing NCDs. So for instance, in policies to reduce the intake of salt or sugar. So what happens in this model? So the model takes individuals and is going to project a trajectory of how they progress through life in health and illness through a period of time until they die. So each individual is defined in the model with the specific characteristics for age, sex, socioeconomic status, deprivation quintile. And all this information is based on, for England, on the Office of National Statistics, the Health Survey for England, and the census as well. So the model also will determine the current risk factors for a particular person and the diseases they will progress through in the period of time. At the end of the model, of a given period, the model will aggregate all the outcomes. We'll look at how many people got certain diseases, for instance, coronary heart disease, stroke, type 2 diabetes, and we'll count them all together as a population. And then we'll know what's the effect of an intervention in the outcomes of a population. So this is how the model can be used to test scenarios of new interventions. So for instance, if you want to implement a policy that reduces alcohol consumption by 10% in the people 20 to 40 years old, then you can model this in the system, in the model, and look at the outcomes at the end of it. So I use this model as part of my training to evaluate two recent interventions that have been implemented nationally. So in modeling, you define scenarios that represent the effect of an intervention. And my first scenario was the NHS Diabetes Prevention Program. You may be familiar with this. The intervention provides a minimum of 13 lifestyle sessions spread over 9 months to deliver advice on healthy eating and exercise, physical activity. And initially, this was delivered in groups, face-to-face. And the effect that I used to model this intervention is a weight loss of 3% in average per participant. And this is provided by data from the program. And also I use a cost per participant of £270 for the intervention. So this is a midstream type of intervention because the aim is to provide the tools to individuals at risk of moving into type 2 diabetes to avoid having the illness or prevent it altogether, avoid it altogether. The second intervention was the UK soft drinks industry levy, which is commonly known as the sugar tax. It consists of a tax to the manufacturers and importers of sugar-sweetened beverages, and the aim is to encourage reducing the amount of sugar in sweetened drinks in the UK. So for instance, in the taxes, if a drink has more than 8 grams per 100 milliliters of sugar, then the manufacturers have to pay a tax of 24p. But if it has less than 5 grams of sugar per 100 milliliters, then there's no tax. So rather than passing the tax to the consumers, the aim is to encourage they reduce the amount of sugar. To model this scenario, I use data from the evaluation for the UK SDIL, which estimates that looks at the purchases after the implementation of this program in the population, and estimated that there's a reduction of 12.5 grams of sugar per person per week. Now, these results are at the moment being re-reviewed, so just treat these results with caution at the moment. So using the impact NCD model, I compare these two scenarios and look at what are the outcomes 20 years ahead in time. The way you do this, you need a baseline scenario. So this is that defines the current standard of care. And so using the model, here we can estimate health outcomes, for instance, for the cumulative number of type 2 diabetes cases in the population, the number of cases prevented or postponed. And here in the graph, we can see how the cases accumulate over time. The blue line is the NHS DPP program. The yellow line is the sugar tax. And the green line is a scenario where both interventions are acting together. So again, need to mention these results are shown for illustration purposes. They are being peer-reviewed, but because the data I'm using to base my effect on the sugar tax scenario is being reviewed, I still have to wait for those data for my paper to be reviewed. So there are other outputs produced by the model. So for instance, we can find about the cost, how cost effective is a scenario. Is just to say if the health benefits achieved over the period of time justify the costs that are paid. So for this approach, usually the government defines some thresholds of the cost per quality, which is an health economics measurement. And for this scenario, I'm using £20,000 per quality. don't pay too much attention to this. So the graph shows the probability of a scenario to become cost effective. So in this case, the UK, the sugar tax scenario, it's pretty much cost effective from the beginning. We can be certain that it's good value for money. The NHS DPP program reaches a probability of 50%. So it's uncertain whether it will be cost effective or not, given the information and the models in the model that we have. And the combined scenario, you can see that after 12, 13 years, the cost of the two interventions balance, and then it starts becoming cost effective in the longer term after 13 years. And the model can also produce the probability of the scenario being equitable. And for our study, the results were not very certain. So implications for this. So modeling methods in public health research can help decision makers to inform the decisions, to improve health, save NHS resources, and reduce health inequalities. So initial results from the analysis shown suggest that more support is needed for upstream policies, such as the sugar tax, if the health outcomes are to be big enough to kind of reduce the cost to the system and improve outcomes in the long term. Again, these results are pending review, but hopefully I'll post a note once there's a peer review of the paper. And the third implication that I want to share is that in designing and implementing new interventions for public health, researchers and policymakers need to consider what are the conditions in a population and the mechanisms for this population to use the intervention that is in place. Because otherwise, you could design and provide the best intervention in the world that has worked in other places. But if the cultural aspects are not there, or any other aspects are not there in the population you want to introduce a new intervention are not there, then the intervention is not going to be used and not achieve the results you expect. So now with establishment of integrated care systems, there is an opportunity for all the relevant partners in a system, including the acute sector, to collaborate in local environments, local systems, to understand the needs of the local population and define interventions to improve the health for the population based on these needs identification. But it's also a challenge because it's not the way things have worked until now, mostly. So population health research can support this work, looking at the identification of needs, identification of possible interventions, and estimating the benefits. So this can inform the decision making for the medium and long term of those agendas in the new local integrated care systems. Future research interest for me is to learn and use methods that meaningfully involve all parties involved, including patients and members of the public, in identifying and designing interventions, initially to reduce non-communicable diseases. And here it's just like a headline of a paper, recent research article that look at the policies implemented by government in the last 30 years. And it found that they have not worked as expected. Mainly the main reason posed is that they tend to target individual behavior, expecting that individuals change their attitudes, their behaviors to tackle obesity or related diseases. Whereas recent research is suggesting broader community solutions are needed. And yes, the NHS is part of that community, so all the partners need to come together and try to understand really what is needed in the locality at a midstream, an upstream, and also maybe downstream level, targeting help for the people most at need. So this is kind of something I would like to keep working in the future.